The White conference gets better every year, and one of its unique characteristics is its huge success in attracting people from different disciplines, and this session is a very good example of that. Instead of having all the IS people up here, we have 2 economists and 1 public policy scholar. So without wasting any more time, I would ask Sunita Desai to start her presentation.
Thank you. So, interoperability refers to providers' capability to electronically exchange patient medical records with other providers and to use the information in those records without additional manipulation by the recipient. So in this study, I investigate how 2 defining characteristics of interoperability affect adoption of interoperable IT systems. The first is that interoperability forms an information sharing network. And as in any network, it's only valuable for a given provider to join if there are other participants already in it. So this is the network effect, and specifically, the network effect refers to the increasing value of joining a network in the number of other participants. The second characteristic is that interoperability involves the sharing of patient records. And patient records may be a competitive asset for providers. And as a result, some providers may be reluctant to engage in information sharing with other providers, some of whom may be their competitors. So I call this information blocking, which is also a term that's being used by policymakers to refer to this type of behavior. So I think it's important to study the factors that encourage and discourage adoption of interoperable IT systems for a couple of reasons. So first, the ability to seamlessly exchange information between providers has a potential to improve costs and quality of care. Acknowledging this, the federal government passed the HITECH Act, in which it invested over $30 billion to promote adoption of electronic health records, health information exchange, and a culminating goal of HITECH is interoperability. So while HITECH has been considered successful in spurring adoption of more basic IT capabilities, as we've begun to focus on more advanced IT capabilities such as information sharing and interoperability, the efforts have largely faltered. And then finally, as I alluded to before, recently there's been a lot of evidence or allegations of information blocking behavior. And just to clarify, the term information blocking is often used interchangeably to refer to providers and vendors. In this work, it refers to provider behavior, although vendor-level information blocking will figure into my policy implications, which I'll discuss at the end. So there hasn't been much empirical work on interoperability, and so it's difficult to ascertain the exact extent of interoperability currently. Interoperability is a little bit tricky to study empirically because it's not just a technology that a hospital adopts or doesn't adopt. Instead, it's more a characterization of the relationship between multiple IT systems. So I attempt to address this gap in the literature by devising a way to measure interoperability or the capability to be interoperable. So I exploit the fact that in general, at least in the current state of technology, interoperability is largely limited to same vendor IT systems. So I use this and I assume it more broadly so that I can define hospitals as being interoperable or having the option of being interoperable if they have adopted the same vendor's IT system. So with that in mind, I have 2 empirical research questions. The first is, do hospitals value interoperability? So if interoperability is limited to same vendor systems and hospitals do value interoperability, then we should see network effects in hospitals' vendor choice. And the second question is, do some hospitals engage in information blocking? So I test this by testing whether hospitals that we expect to be vulnerable to losing market share demonstrate negative value for interoperability. For this analysis, I used 2 related data sets. The first is a national hospital-level panel dataset from years 2009 to 2012. And the key variable here is hospitals' vendor choice. And I focus on vendor choice for clinical data repository software because that is the capability that's most closely related to information sharing. In the second analysis, I incorporate some hospital-level data on the patient population seen by the hospital. I aggregate this data from states of California, New York, Florida inpatient databases, and so this analysis is limited to hospitals in those states. Okay, so the first question is, do hospitals value interoperability? So hospitals are choosing between multiple vendors, and they'll adopt the vendor that's most profitable to adopt. And profitability from adopting a vendor is determined by vendor characteristics, hospital characteristics, and potentially the installed base, or the market adoption rate for the given vendor. So if hospitals value interoperability, then they will place weight on installed base of a vendor when choosing a vendor. And so in this profit function, if hospitals value interoperability, then beta will be positive. And this would also be indicative of network effects in vendor choice. So I adapt the profit function to a multinomial logit estimation model. So the dependent variable is the vendor that hospital I, is whether or not hospital I adopts vendor J. And the explanatory variable of interest is the installed base for vendor J in the market. And of course, in calculating the installed base, I exclude hospital I, but I also exclude all hospitals from hospital I's system so that I'm not overestimating the network effect because of some within-system correlation in adoption. So, and then I also include some hospital characteristics and vendor fixed effects because I don't have other vendor characteristics. I put in vendor fixed effects. So here, if beta 1 is positive and statistically significant, then we have evidence that hospitals value interoperability, or we have evidence of network effects in vendor choice. Because we might be concerned about potential endogeneity affecting adoption behavior by hospital I as well as other hospitals in hospital I's system, I instrument for installed base using adoption rates from hospitals outside of the market, but within the system of hospitals represented in the installed base. And since the second stage is nonlinear, I run a two-stage residual inclusion model. So the results from this analysis indicate that hospitals do show value for interoperability, or we do see network effects in vendor choice. So in these results, the first two columns are the multinomial logit results, and the third column is the two-stage residual inclusion, and the fourth column is the first stage. So you can see that across the board, the installed base coefficients are positive and statistically significant, and to interpret these multinomial logit coefficients, taking column 3, we can say that if the probability of adopting a vendor is 0.5, then a 10% increase in the adoption rate of a given vendor leads to a 1.5% increase in the likelihood of a hospital adopting the vendor. And so we can see that while hospitals do put weight on the installed base, it seems like they're placing more weight on other factors when deciding to which vendor to adopt. Okay. So the second question is, do some hospitals engage in information blocking? So I want to define hospitals that we would expect to potentially information block. So my measure for vulnerability to losing market share is the fraction of patients that go to hospital I and go to another hospital in a given year. So if a hospital has a higher portion of patients visiting another hospital in a given year, then I say they're more vulnerable to losing patients. So I interact this measure of vulnerability to losing market share with the installed base measure, and then I run pretty much the same specification. And so here, if beta 1, the coefficient on the interaction, is negative, then we would have evidence of information blocking. So we would be able to say that hospitals that are more vulnerable to losing market share are less likely to adopt a vendor that is prominent in the market. These are the results of that analysis, and they indicate evidence of information blocking. So you can see that the coefficients on the interaction are positive and statistically significant, are negative and statistically significant. And so this is saying that as a hospital's portion of shared patients or vulnerability to losing market share increases, they're less likely to adopt a prominent vendor. So if we take column 2 and we can interpret this as if the probability of adopting a vendor is 0.5 and a hospital shares 16% of its patient population, which is the sample average, then a 10% increase in market adoption rate of a vendor would lead to a 1.1% decrease in probability of adopting a given vendor. So I think this is a stark finding, especially because these hospitals that have patients that are visiting other hospitals are precisely the ones whose patients would benefit the most from interoperability. But here we're seeing that they're less likely to adopt interoperable IT systems. So in summary, I find evidence of modest network effects, and I also find evidence of information blocking among hospitals who share patients. So I think these findings illuminate 2 reasons why we might be seeing low rates of interoperability. First, while hospitals appear to value interoperability, it's lower on their priority list. So they care more about other characteristics when deciding which vendor to adopt. So when we have modest network effects, it can lead to splintering, which is essentially the formation of multiple information sharing networks with a couple hospitals in each that can't talk to each other, thus defeating the purpose of information blocking. To address this, policies should focus on emancipating interoperability from vendor control. And I think there's 2 broad strategies to address this. So the first would be the government or some industry group creates a common technical standard and mandates that vendors have to adhere to that. So there have been many attempts at this, and they haven't really been successful at getting off of the ground. But I think that even if such a standard was effectively enforced, there are reasons we should be wary of it. Because generally, when a standard is set, it isn't updated to keep up with changes in technology. And so such a standard would inhibit innovation, reward organizations that don't innovate. And especially in a rapidly advancing industry such as health IT, I think that could be harmful. And so I think policies should focus on enabling the entry of third-party developers to offer adapters that hospitals can adopt and be interoperable with other hospitals regardless of their vendor. So examples of policies could be policies that bar contractual clauses that allow vendors to hold patient data hostage, or policies that encourage intellectual property sharing between vendors and developers for these purposes. And so such a market-oriented solution would not inhibit incentives to innovate, since vendors could continue to innovate and the developers of these adapters would have market forces to incentivize them to innovate also. The second reason why rates of interoperability may be low are information blocking. And it's unlikely that the meaningful use payments are large enough to overcome the concerns of these hospitals about losing market share. I think other reforms that encourage alternative models of care can help to reduce incentives to information blocks. So for example, accountable care organizations and patient-centered medical homes encourage care coordination. So I don't think that they can be a panacea because competition between providers are likely to persist, and at the least competition between ACOs is likely to exist, but I think they can help. So in conclusion, interoperability is an important capability. It's important to realizing the full value of IT. In this work, I've shown that hospitals show modest value for interoperability and that some hospitals engage in information blocking. And these findings help to explain why rates of interoperability may be low and policy efforts should focus on reducing provider incentives to information block and free interoperability from vendor control. Thank you.
Colin, yes.
Yeah, if I could use this mic, it would allow me to lazily consult my notes. And if I say something incorrect, Sunita can kick me under the table. Nothing. Thanks very much. My name's Colin Baker. I'm a health economist at ASPE at HHS, and very much a dilettante on the subject of health information systems, the economics of it. So compared to most of the people in the room, so bear with me if I seem silly to you. But anyway, this is a delightful topic, the subject of encouraging interoperability in health information systems, replete with externalities. It's a perfect public policy conundrum. We think that health IT systems show positive network externalities, and so, since individuals can't capture the benefits of it, we expect markets to underproduce them. If I'm an IT vendor, once I've got my bulk of consumers and others buying my product, I'd like to differentiate my product from others, make it incompatible to capture some of my customers. That's a strong incentive that I face if I'm a dominant IT vendor, and it's not necessarily something that leads to a social optimum. The other issue about it is that healthcare providers are interested in keeping patients in their networks, and one way they can do that is to make their health information systems incompatible with others, so as to keep their patient networks whole and make it harder for patients to switch to others. And that's where this paper comes in. This is a great interest at the department today at HHS. The Office of the National Coordinator is very interested in this subject, and there are very few papers on it, and this is a real contribution. I think it'll be very helpful. So basically, three questions asked here. The first, do hospitals value interoperability? And the paper looks at it, examining vendor choice. A couple of thoughts here. First of all, the paper very sensibly defines interoperability as having the same IT vendor, which has the great benefit of it being very correct. I mean, certainly that's interoperable if it's the same vendor. I don't know how to do this, but I'd like to suggest for the future that we sort of think of some sort of an index of interoperability, maybe something ranging from 0 to 1, where if it's the same vendor, that's 1. If it's completely incompatible, it's a 0. And then on the basis of input from people who know a lot more about this than I do, some sort of degree of interoperability. There have to be some sorts of IT systems that are reasonably compatible with one another. It'd be interesting if we used a more sophisticated index. Again, I don't want to be the one to have to come up with that, but it would be helpful. The second thing, reading the first of the three, there are three general analyses. Looking at the first one, I kept wanting to see an interaction of your key variable with something like hospital characteristics. Like, for example, hospital size. You do that in the third analysis. You look into different types of hospitals by size. I would expect, if the question is how much does a hospital or healthcare system value interoperability, there have to be all sorts of characteristics of hospitals that are easy to see that we can look at how the value would differ. Academic centers would probably have a very different value placed on interoperability. I would look at that separately, or interaction term, or however you like to do it. For-profit hospitals versus others. I thought that the instrument that's used for the installed base is pretty clever. If I had more time, I'd like to get into that, but that was a neat effect. So on the subject, having found modest effects on the whether or not the hospitals value interoperability, I'm thinking maybe that's a result of a coefficient very different for subgroups. I don't know, but maybe that's the case. Maybe it's big for some and small for others. I think it's worth looking at, if the data allow it. The second question on HIEs I'm going to skip because I want to get right to information blocking, which is nearer and dearer to my heart. The third question, how much information blocking is there, basically? Or to be more precise, do more vulnerable hospitals or providers information block more? Or to be even more precise, do they choose the non-predominant IT vendors? Meaning that if I'm choosing one IT system that's compatible with all of my competitors, or I can choose another one that is not, which will help me keep my share of patients. One issue in there I had, this is a hard thing to define, but the variable is defined in the paper as the fraction of shared patients. And if I understand it, it's defined around the hospitals that have had an individual hospitalized at my place and also at one of the competitors. Is that how it is? Okay, so I think that's certainly, that is a measure of vulnerability as you've defined it, but I think it misses a lot. There's what you'd like ideally is some sort of set of covered lives that are captured within your network versus a set of covered lives outside. Again, I don't know how you do that. I don't know if the data are available, or it might be available only in certain regions, but I would think that you're missing a lot of the juice that you want in that variable. But the interesting thing is, with all that said, and I was thinking maybe that's not the right way to define it, your estimate does exactly what you'd expect it to do. So maybe it's a lot better than I thought it was. It seems to work very well. The final question on hospital size, you find results that are not consistent with some of the previous work, which is very interesting. I would return to the question of looking at, say, academic centers versus non-academic. If they're bigger on average than non-academic centers, maybe that's where the explanation is. For-profit versus not-for-profit. Out of time.
Thank you very much.
Sure.
So the next presentation is from Marty Cohen on testing theories of innovation diffusion, analysis of physicians' adoptions of EHRs.
So in order to get through this in the allotted time, even though this is a quantitative analysis, most of the quantitative details of my study I've included in a number of backup slides in the slide deck. So anyone who is interested in more of those quantitative details of my data or my results, certainly when you download the slides, you can see all that. Okay, so I was interested in looking at physician EHR adoption from the perspective of several of the leading theories on what drives or constrains the rate of diffusion, the breadth of diffusion of an innovation. So, for example, one theory that the principal driver or constraint is differences in the profitability of adoption across potential adopters, different circumstances for different potential adopters, sort of something in particular economists would look at about profitability and the costs and benefits. Second theory I wanted to include was the idea that it's differences in information among potential adopters, would-be adopters. This can be things as basic as awareness of the innovation, but it can also be things like the level of expertise you have to implement the innovation. For something complex like an EHR system, which is so fundamental to how you deliver care, certainly your level of expertise and differences in that is a big deal, and so on. It can also just be your general sense of risk about it. That's sort of another information issue, how much uncertainty you perceive about adoption. And then, particularly the theme of this panel, the idea of network effects. And as we already heard, sort of the idea of network effects in particular that I'm interested in is the idea that the return on adoption increases with the number of adopters. But as we heard in the first paper, that requires interoperability. And the literature on network effects would suggest that if you don't, that you get interoperability typically with IT either from promulgation of formal standards or some early market convergence on a dominant design, like Microsoft for operating systems, and that sort of leads to a dominant design which becomes de facto interoperability as everybody has to line up under that dominant design. Certainly these are not mutually exclusive. There's overlap in this. It's not an all or nothing situation. And in the case of EHR adoption literature, all three of these have been cited as concerns, including among physicians. So my specific research question to look at this is among small physician-owned practices in the U.S., to what extent is EHR adoption status predicted by the physician's views on each of 5 factors that I could look at in my data? The value of improved information as it relates to adoption, sort of information that would support adoption decisions, the impact of the HITECH Act's financial incentives, the Meaningful Use Program, challenges for a practice in selecting a specific EHR product or vendor, which goes to sort of the network effects issues, the direct financial cost of adoption, and concerns about actually implementing the EHR in the practice. I wanted to focus in particular on small physician-owned practices, which I defined as 10 or fewer physicians, for a couple of reasons. My methodology relies on survey data, and I wanted to make sure that I had survey respondents who were particularly likely to be knowledgeable, to have the institutional knowledge about the adoption decision in their practice. So if I had very large practices with 50 physicians, or practices where they're owned by a large organization like a hospital or an HMO, it's very likely that the adoption decision would have been made at a more distant level, and the individual physician in my survey may not have been very knowledgeable about what drove it. So I'm focusing on the small practices for that reason that were owned by physicians. Also, because this particular population has lagged somewhat in their adoption rates, that makes them particularly relevant to high-tech policies to try and boost adoption. So for my data, my primary data is a 2011 survey, a national survey of physicians run by the CDC. The survey included questions, a series of questions that asked both non-adopters and adopters about different issues they may have considered in their decision on whether to adopt. And it was a gamut of issues, so things like the value of the government certification program for EHRs, the effect of the high-tech financial incentives, both the positive and the negative, but things also that were predating high-tech, the opinion of trusted colleagues and the EHRs that trusted colleagues may have experienced or talked with other colleagues about, concerns about selecting an EHR and challenges, the cost of adoption, both the upfront cost and the annual cost, things like that. I had a pretty good sample size of a little over 1,000 physicians in my defined study population, and a pretty good response rate in the survey of a little over 60%, and so on. So my approach was to take these 19 survey questions on these different possible issues that were considered, and based on a factor analysis and my own judgment, I grouped them into 5 composite scales that reflected the underlying factors that I mentioned in my research questions. So for example, the value of improved information, the impact of the high-tech incentives, the cost of adoption, etc. And then I used logistic regression to test the significance of all 5 of those scales in predicting adoption status among those physicians. I controlled for things like physician specialty and age and practice size and location and so on. For sensitivity analysis, I specified a series of different logistic models that varied on several dimensions. So one dimension was, I used, in one version I used a simple binary dependent variable that you're either using an EHR at the time or not, just a simple yes-no dependent variable with cross-sectional data for 2011. In a second model type, I tried a 3-category dependent variable with a multinomial model where the possible adoption statuses to predict were that you could be using an EHR, you could be in the process of adoption, or you could be not yet even in the process of adoption at the time. And then third, for a subset of my data, some of those respondents also responded to the survey in the following year in 2012, and I was able to do a longitudinal model where I looked at physicians who were non-users in 2011 and tried to predict, to see which of these scales were predictive of who shifts to becoming a user in 2012. And then I also varied the models in terms of what population I included in the data. I looked at my full study population in some, and then in some I took out adopters who were predating the high-tech period so that I could focus the models more closely on decisions being made during the high-tech era. So as I said, my detailed quantitative findings are in some backup slides, but just to hit some of the high points. So regarding my variable for the influence of improved information on an adoption decision, physicians who reported improved information as important to their adoption decision turned out to be much less likely to have adopted by 2011. I think that makes sense. If you think about later adopters, they tend to be more cautious. They need more reduction in uncertainty about adoption before they're willing to commit, as I said, especially for something complex like an EHR. And I think my findings consistent with that the laggards were feeling more of an information need, that they needed more information about the effects of adoption and the feasibility and so on. But once I focused on physicians who had either not adopted by 2011 or were on the verge of adoption, in terms of trying to predict that, the information scale was no longer a significant variable. It wasn't statistically significant anymore. It was highly significant when I looked at early adopters versus the later adopters or non-adopters. So I don't have the data to definitively explain that, but one of my conjectures in the paper is that that may be a sign that under the HITECH Act, perhaps some of the information needs and the information gaps among the remaining potential adopters, perhaps those are narrowing from all the multiple mechanisms where HITECH is putting more information out there. But as I said, that would require further research to confirm. Regarding the high-tech financial incentives, my models that isolated decisions in the high-tech period were very consistent in finding that the degree of importance physicians attach to the meaningful use incentives is a very strong predictor of recent adoption. For example, in my two multinomial models, a 1-point increase on this 3-point scale I created for the incentives influence, it increases the likelihood of being a recent adopter relative to remaining a non-adopter by over 300% or more. In one of the models, it was as much as 500%. And also in my longitudinal model, where again, I started with non-adopters in 2011 and tried to see which factors predict who becomes an adopter by the following year, only the incentive scale, that was the only one of my scales to be a significant predictor for that. Regarding network effects, as I said, in the absence of interoperability or a dominant design, the literature on network effects would suggest that a lot of the potential adopters would hold off committing to adoption out of concern about which particular version or vendor to select, to commit to, out of fear of obsolescence, or that that'll prove to be the one that isn't going to be interoperable down the road. But in my model, the scale for concerns about selecting a specific vendor or product was not a significant predictor across any of my models at conventional significance levels. And I think that's supported by some other data from a study I looked at by Gold and al. In 2013, where they looked at market share data for the physician EHR market as of late 2012. Over 350 different vendors had sold an EHR to physicians or professionals who were in the meaningful use program by 2012. And the largest single market share among all those vendors was about 20%, and the top 75% of the market share is spread among 16 different vendors. So a very unconcentrated market, and not the sort of behavior that the network effects literature would predict if you've gotten to this level of fairly broad adoption by this point. So some of the limitations in my study, the composite scales I'm relying on for this, they're certainly imperfect measures of these underlying constructs I'm trying to look at. They're somewhat blunt, but I think the scales have good face validity. In one of my backup slides, I list all the specific questions that I grouped under the scales, and I think those generally kind of make sense. And also, one of the conventional measure for how consistent a scale is in measuring a single underlying construct is Chromebox alpha. All of my scales had very good results for Chromebox alpha, so again, I sort of felt okay with that. And in particular, I think as long as I'm not overemphasizing the specific sort of percentage impacts from my odds ratios and my risk ratios, I think the scales are useful for providing general comparative indicators of direction and magnitude of effect at least. I already mentioned the risk that some of the respondents might not have enough institutional knowledge about the decision making, but as I said, I tried to mitigate that in how I defined my study population, and also I excluded any responses from the survey where it was an office staff member instead of the actual physician who had completed the survey. Another limitation is clearly I'm not addressing all of the factors that can influence adoption. One of the other major theories, for example, about diffusion is the epidemic model. You're all familiar with, I'm sure. I didn't have the data to really do a test of the epidemic model. And even some of the specific policy issues that might influence adoption, like legal concerns, privacy, data security, that wasn't in my data set where I could really look at that either. So as far as some implications for policymakers, my finding about the influence of the government-imposed financial incentives, I think is indicative that to the extent government in particular is trying to promote other innovations where the business case for physicians adopting may be somewhat weak, that making sure that the promotion program, the policy, has explicit government-imposed sort of financial incentives to improve that business case, I think that's very important. Things like the patient-centered medical home model model come to mind that CMS is doing a lot of work to try and promote right now. My finding on the value of improved information for later adopters rather than early adopters, I think that also has a lot of implications for current government efforts to promote other innovations. So for example, again, CMS really puts a lot of effort and resources into technical assistance when they're putting on demonstrations to test adoption of innovations right now. And so a lot of data sharing, as I said, a lot of technical assistance and that kind of thing. But the fact that that kind of support might be more important to the later adopters, I think raises some real questions about how you scale up when you go national. And one of our presentations this morning talked about that challenge about scaling up from a single pilot to a national program. And then lastly, in terms of network effects, I think that given that we've now sort of reached not certainly total adoption across physicians, but certainly a very high level of broad adoption at this point, although you can question how deep it is, but the fact that we've gotten there without a dominant design at this point means that achieving interoperability is going to be much more difficult. Clearly that's sort of rising on the policy agenda now, and so getting those benefits is going to be more difficult. We're not getting the benefit of the market forces that the network literature, the network effects literature would normally expect. I'll stop there.
Thank you very much. The discussant for this paper is Dong-Gil from University of Connecticut.
Just for the record, no, I did not change employment. I'm in University of Cincinnati. So UC and UC, we think alike, I suppose. So,
this is University of Connecticut.
I know. I realize that. First of all, I'd like to thank White for inviting me to be a discussant. It's a pleasure to be here and giving me the opportunity to comment on this particular paper. So first of all, there's a lot to like about this particular paper. So let me, without trying to repeat a lot of things that Marty has mentioned, let me try to highlight some of the things that I found to be interesting that I would like to share with you. First of all, I think Marty, I think about Star Trek. He's chartering places where nobody has chartered before, and because it's underexplored area. And I think it's also timely because he is examining the small physician-owned practices. And so there's not a lot of research in this domain. There's a lot of research around, large-scale hospitals or bigger scale physician offices and whatnot. So I think this is one of his contribution, and he's limiting to less than or equal to 10 physician practices. So again, very small. Another thing is that we've heard a lot today as well. There's a lot of focused around customers, customer view, or even hospital view. But little attention has been discussed around the physician's perspective. So that's, I think, another contribution that he's bringing to the table. So there's a lot of focused around patient-centered programs and the outcomes thereof. So it's interesting to kind of bring the physician's perspective into the picture. And you should read this. I encourage you, all of you to read it because, again, there's a lot to like about this. There is this greater understanding about these facilitators and inhibitors of EHR adoption among small practices that he is examining. So just, again, a little bit of a background. He is introducing this diffusion of innovation theoretical framework to answer his research question. And what's nice about the way he positioned the paper is that he has introduced these elements as the barriers to adoption, and then he goes on to conduct additional literature review in talking about government intervention policies and how they are addressing these very barriers. There's some good synergy in the paper in terms of the flow, and really carries the reader in helping us understand exactly where it's taking the paper. I like the visual aid, so one thing I would have appreciated was some sort of research model. So I took the liberty of doing this. I hope it's accurate. So basically, he has 5 independent variables with 1 dependent variable, as you see there. Okay, so he's interested in the physician's adoption of the EHR along those 5 independent variables. So let me just highlight some of the things that I felt to be pretty important and interesting. He did use this multi-model approach using this 2 cross-sectional National Center for Health Statistics survey data, as he discussed. One of the challenges associated with this is that as I was reading it personally, I got caught up with so many different studies, so many different analyses, that sometimes I would lose focus on how which model really meant with what. So it's possibly focusing on, while the sensitivity analysis is very useful and helpful, maybe reserve that for supplemental slides perhaps, or supplemental notes or appendix, but focus heavily on the key core concepts and maybe 2 different models perhaps. So just one quick suggestion around that. So as mentioned, one of the findings is that this cost continues to be the most important barrier to adoption. Another interesting finding was that, I thought this was very interesting, improved information perceived as influential to their adoption. However, these folks were less likely to adopt. So I'm going to touch upon that a little bit later. And that network externalities is what I'm calling here, is basically suggests that there are these benefits of adopting later. However, this was not observed. And what was interesting is that 48% of the survey respondents had adopted at the time of this initial survey. And if you kind of put that together with what Glenn Tobin said this morning, as of 2014, I believe, there were over 80% who has already adopted EHR. Now, I don't know if they include the small practices or not, right? But that's something to consider. So potential ways to look at this is, as far as the cost is concerned, I think cost is going to be an ongoing issue, ongoing concern, but maybe I see a lot of resemblance with the EHR adoption to that of the ERP adoption. Started with the large companies, enterprises, and start going slowly to mid-size, then to small size. So I think that maybe examining the stage approach to adoption could be a useful analogy to look at how small physician offices could adopt with the consideration of the cost. The other aspect of this improved information is that maybe I'd like to see some sort of interaction effect, because you would assume later adopters are more knowledgeable. They have more knowledge under their belt. There's more lessons learned. So they might be inclined to be able to better adopt, or be in a position to better adopt. So maybe interaction effect, putting cost, knowledge, maybe even fear that was discussed in the paper. And then review second, there's a strategic management literature on second mover's advantage, not just a first mover advantage, but second mover's advantage, maybe looking at that to examine the network externalities. So I'll leave this, I'll pass these slides to Marty, but these were just additional remarks and comments because I'm running out of time. But let me conclude with the following. As I was listening in, I thought maybe Sunita and Marty should get together, because I think there's a lot of collaborative effort that you guys can get together and work on, given her research on network effects. Thank you very much.
Thank you very much.
Okay, I'm Frank Limbrock from the Colin School of Management. This is joint work with Mariano Irase, who is a PhD student in the Department of Economics at Northwestern. Well, we are very grateful for this opportunity to present our work. This is very early work, so all of your feedback can be really utilized in a big way as we shape this project going forward. We should also thank the NET Institute for supporting this project. Okay, I had to edit these slides in the break so that the people in this side of the room could still see the great pictures. I scarcely need the introduction anymore. Why is it interesting to look at network effects in EMR adoption? General definition of network effects is an agent's payoff from technology depends on other agents' adoption decisions. Most of the time we think positively, not always. Prior literature focused on the hospital segment mostly. For typical Miller and Tucker, 2009, identify network effects from adoption decisions in this way. Basically, they're saying, okay, how if the hospital in the oval is the one we're looking at, how does the fact that several around them have already adopted influence their hazard rate of adopting in any given year? What are the identification issues here? Basically, since you're relying on this clustering for identification, you want to be sure that you're really picking up the network effects rather than just a shared unobservable that creates these clusters. Just a marketing effort distributed across the country in differential ways, or some local taste for being a technical pioneer. Some of these issues those are still also an issue if you look not at just adoption 01, but at vendor network effects within vendor. So what do we do? In this paper, we focus on the physician segment, and we identify network effects from physician vendor choices. What we utilize here is the structure in US healthcare where There are connections between different providers in the healthcare value chain, and we're looking at hospitals and office-based physicians. What are these connections? A lot of hospital admissions are referrals from doctors or admissions from doctors. That's one way they're connected. The other way they're connected, in the US anyway, is that a lot of physicians do both work in their office and in a hospital environment. And we're using both of these measures of connections to establish these connections. So basically what we're doing, and even if this takes a minute, this picture here gives a very nice informal sense of our identification strategy. If you think of these boxes as hospitals and the colors representing different vendors these hospitals have chosen, these circles with these little dashes, I don't know why they are there, represent doctors who are thinking about adopting. This doctor here, for example, has connections to these 3 hospitals, and I indicated this connection to the blue one as stronger than the other ones. And basically, what our identification strategy is: if this doctor is then more likely to go with the blue vendor, that could be Cerner or something, than a doctor around the corner who is also interacting with several hospitals, but is mainly interacting with the red one, then we take that as evidence consistent with network effects. Again, these network effects could have different sources, either direct data exchange, interoperability, or it could be in the context of working both in the office and at the hospital. It could be simple things like having a graphical user interface you're already used to. Right? Why do you care if you're not an EMR marketing executive? Well, in this room, we don't have to say it. We've heard enough to know that interoperability seems to lack of interoperability seems to hamper EMR's benefits coming to full fruition. Right? For us, it's also part of a larger research agenda, which is what is the effect of this fragmented EHR adoption on referral patterns and hospital competition. Can a hospital, in a similar way of the information blocking, can a hospital make its patient base less contestable by making its if the neighboring and closely connected physicians are using the same EMR? Are those then more likely to send patients their way? Okay, I've said most of this before. What do we do in this paper? We follow the basic approach in using adoption decisions to identify. And what we're doing is we investigate the effect of installed base of a vendor in the hospital market on adoption decisions in physician market in Florida. Why Florida? In Florida, we could identify the attending physician in every inpatient discharge in the HCA data, and we could get both Medicare and Medicaid physician EHR incentive data. That's why we started off with Florida. So the question is basically, does a physician derive more value from a given vendor's EHR if her most closely connected hospital uses an EHR system from that same vendor? Definition of most closely connected is going to be either most of that doctor's inpatient discharges are at that hospital, or most of that doctor's referrals are to that hospital. We think that this approach alleviates a lot of these identification issues. Why? For one, in general, hospital adoption seems to have happened earlier than physician adoption. And also, physicians are in general small compared to hospitals. So a lot of these strategic incentives that you might think of, that make it harder to identify network effects in between hospitals are, we think, alleviated here. So that means that while, if you look at hospitals, you always need an instrumental variable strategy, for example, to get identification. We think a lot of these things are not as much of an issue here, so we don't need those special identification strategies. Okay, that's the basic story. What's our empirical specification? We define the utility of to Dr. I of adopting vendor J as represented by this expression. I want you to focus on this beta times I vendor of the hospital that's closely connected equal to the J, the vendor that's being considered. This may be a bit too abstract, so basically you can see this here, the I and this curly bracket, as basically a same indicator. This is 1 if the considered vendor J is the same as the hospital's, 0 otherwise. What is all this? Of course, we want to control for the average popularity and things like prices of each vendor. That's the alpha J's. But we go further than that to speak to this problem of whether what we're seeing is genuine network effects and not just shared unobservables, which could be shared between hospitals and doctors. We put in a full set of vendor-region interactions. Vendor-region interaction dummies, so they basically allow for each one of these vendors to have a different level of overall popularity and overall attractiveness in each of the markets. So we control for all this, and any effect that we pick up with our main coefficient of interest is really, we hope, a network effect. If these epsilons are IID extreme value, this leads to standard low-jet probabilities that we can estimate with a standard maximum likelihood procedure. What are the data we use? We used 2013 Medicare and Medicaid EHR incentive program in the physician meaningful use attestation data for physicians. We think these are high quality data, and attestation of meaningful use is required to obtain these substantial incentive payments up to $40,000 plus. On the other hand, if these payments are a strong incentive to attest if you actually have met all these conditions. So this is not just checking a box on a mail-in survey. You actually have to demonstrate that on all of these kinds of different measures you hit the benchmark of meaningful use. Because of this data, because our data only has adopters, we have to take the adoption of the HR system as given and only investigate the choice of vendor. We can't speak to which doctor adopts versus not or later. Okay, these are technical restrictions. Just a little graph because it's I think it's easier to grasp than if we put this into bullet points. So we got these meaningful use attestations. These come with these long alphanumeric codes. These allow us to look up with a different file to see who the vendor is. So we know this Dr. Smith, Epic is maybe not the best example, used a particular vendor system and attested for it in 2013. Then we look at the HCA hospital inpatient discharge database and see, okay, we can see which hospital is the one where this doctor had the most admissions in that year, the plurality of admissions in that year. If we're using referrals, you can think here instead saying which is the hospital that the physician made the most referrals to. These are the reasons we used. We aggregated up from HRRs a bit. Of course, this helps us with degrees of freedom, but we also genuinely thought that marketing effort is more on the metropolitan area level rather than on the smaller HRR level. Okay, what are our results? I go straight to here. This is our preferred specification, which has all the vendor region interactions. So basically, anything about, if any vendor is more popular in any given region, if the average discount of a vendor in a particular geographic area is higher, these things would all be captured in these vendor region interactions. So what we would see here is still the full. It's really the full. It's really only what we think of as the network effect. We find a significant same vendor effect. Physicians are significantly more likely to adopt the same vendor as their most closely associated hospital, ceteris paribus. And this is really where all the action is because we're controlling for these region vendor fixed effects, region vendor dummies. This is economically significant too. This is a nonlinear model, so it's not that easy to glean that much from this coefficient. So we put it into an example. For example, in the Miami region, Epic becomes 31 percentage points more likely to be adopted if that physician's hospitals happens to also be using Epic. Cerner, Allscripts has a similar sized effect. Cerner a bit smaller, but off of a very small base. So, and for Epic and Allscripts, this amounts to a 4-fold increase. So quite strong effects indeed.
Can you look at a time lag between the physician adoption and the hospital admission?
Can we? This we should do later. This is in a table in the paper, but it didn't fit in here for time reasons. But I'm happy to talk about it later. Okay, we made a couple of cuts to see if we have differential effects. It has been suggested that Epic provides much stronger interoperability between different event providers using Epic. That's why we looked, that's one reason. The other reason is that it has been suggested that Epic relies much more heavily on hospitals as marketing multipliers. So for those two reasons, it might be interesting to look at the effect for Epic versus all the other hospitals. Epic is much stronger, but the effect for all the other hospitals is still significant if, as you see, something like 1/3 of the size it was when you had all of them pooled in our original preferred specification. We find no differential effect for primary care providers. We thought there could be something because of their different position in the healthcare value chain, but we don't find anything here. Those are the main headline results. Some robustness checks you might want to see, and we have time for them. Here you're thinking, okay, is this just a story about doctors who spend most of the time in a hospital? So we limited the sample to only doctors who in the Medicare Part B utilization and payment file, completely different data set, have less than 50% of their charges in a hospital. So these are overwhelmingly majority office working physicians, and we find actually for this very different sample a remarkably similar coefficient, I think. So it's not completely driven by mainly hospital-based physicians. Also, you might think, okay, wait a minute, why are you using 2013? So we went back and got earlier discharge data to establish these links between hospitals and physicians to make sure that the links we see are not already a result of the interoperability we want to see, right? So that makes these results probably more trustable. So we're glad to be able to obtain and integrate these 2011 data as well. Okay, and finally, as I said, in this specification, instead of using the same doctor doing inpatient discharges as an attending physician, we use their referrals from the beautiful Medicare referral data set that was obtained on a Freedom of Information law by somebody. And we find qualitatively similar results, even a bit stronger. This has some advantages. We're getting more physicians who are not involved in inpatient care. So you see the sample size got up, so we got more potentially different kinds of physicians. And you could think that a physician who never is attending in a hospital is less exposed to kind of a marketing push by the hospital vendors, marketing associate at the hospital, or even to the pressures of the hospital. So if we use referrals, we still get a quite similar effect. In conclusion, we find what we think is evidence of significant network effects. Due to our, again, the central role, due to our use of region vendor controls, we interpret these as direct network effects from interaction in the healthcare value chain. It doesn't include these potential, what you might call ecological effects. So we're only measuring direct effects. If there are other effects, like it's just good to be in an area where a lot of people are have worked with Cerner, so it's easier to hire people. That's a genuine network effect, but we're not measuring it because we want to be very careful about excluding these regional effects. Limitations and remaining issues, we're beginning to run other specifications where the physician group is the decision-making unit, because there's some information out on which physicians practice together. There's some issues there. It's not clear that that is the better specification, but preliminary results show similar effects. And of course, we want to make sure that vertical integration doesn't drive all this, but it's hard to get good data there. One last extension I want to mention here is, since the referral data is national, if we just use the Medicare incentive payment data, we can extend the referral-based analysis to the entire U.S. And it looks like it's not ready for prime time, but results so far look qualitatively similar. Thank you very much.
Thank you very much. Okay, so this paper analyzes the effects of network externality and physician choice of EHR in Florida, and basically shows that physicians are much more likely to adopt the same type of EHR that their local hospital have adopted. Overall, it's a very neat empirical analysis, and I like it very much. However, I have some overarching comments, not only about this paper, but I also noticed that Sunita's paper also I have that question about that, and that is this assumption that if two medical providers have the same type of EHR, then they can magically interoperable, talk with each other and become interoperable. It's not the case. So not all EHRs are interoperable, and it's a very important assumptions that you're making, because all the effect that you expect to observe from network effects is basically if you and I have the same type of software, then we can talk with each other. But it's not the case. Even if we have the same type of software, it doesn't mean that we can't talk to each other. So first of all, not all EHRs are interoperable, and not all physicians benefit from interoperability. So previous research shows that if you have more patients referred to you from others, then you logically benefit from interoperability, because you can look at the records that are being created in other places. But if you are a physician that does not exchange any patient with other hospitals or other physicians, then the value of interoperability for you would logically be lower, and thus the network effects would be much weaker. And so I think given these questions and the results that you're seeing, I think it's not the network effect that you're looking at, it's the marketing effect and results of HHS policy. So one example is that the Office of Inspector General provides safe harbor from anti-kickback laws, specifically within the health IT, so that the hospitals can pay upwards of 85% of the cost of an EHR to a physician, so that when Johns Hopkins Hospitals adopts Epic, then it tells all of the other physicians who are affiliated with that if you are going to adopt Epic, I'm paying 85% of your cost, so that it drives everybody to go and adopt Epic. The other one is that, again, you had a very large effect from the Epic side. Their marketing strategies are very different. For example, Epic does not sell its software to individual physicians. It only sells to large hospitals. So physicians can only have Epic if the large hospital asks Epic to connect them to the hospital. So if I'm a primary care doctor in my own office, I cannot call Epic and say, hey, sell me a software. Say, go find the hospital that can sell you the software. It's like having access to academic journals. It's very rare to find a person buying individual access. We all have access to these journals through our university affiliation. So Epic is like that. And then So that's why you see when a hospital adopts Epic, then all the other physicians who are connected to it will suddenly have Epic. It's not because of interoperability and network effects. I think it's because of the marketing and policy. So I think to address some of these questions, you can take the interoperability of different EHRs into account. So see which of these EHRs, I think this was the comment that was given before, see which of these EHRs are better in interoperability, and see if you see a stronger network effects among hospitals that adopted that specific EHR. And also take the specialty of the physicians into account. I think, the more patients you receive from a hospital, the more likely it is that you be affected by the hospital's decision or hospital's choice of EHR because of the network externalities. And also, exclude Epic, which you have already done, and see if you see the results, which somehow confirms my suspicions because your effect weakens a lot more. And also, think about the other approaches to interoperability. Again, in the areas where you have successful HIEs, then you may see a much stronger effect because people can connect to each other through HIEs as compared to regions where you don't have any HIE. And the very last comment that I just thought about here, you're only including the physicians who have adopted HIE, who have adopted EHR in your system, and you're excluding the ones who have not. So, correct me if I'm wrong, but I think you have a classic example of sample selection. So these are my comments. And I think we can have a couple of questions.
So all the panelists brought this up that interoperability as defined in the limited EHR-related research that have been done. But there's a ton of literature in the IT field or MIS field on interoperability, and the kinds of issues that we are dealing with look very similar to what happened when electronic trading platforms came up, financial markets, and it was almost like if I have a business need, if Chase wants to do any trading with, especially Sunita, you have some financial background, they would go out of the way to figure out how to integrate the back office, legacy systems. So all kinds of innovative ways were used to create those interfaces. So my question is, would you reach out with any of the researchers have reached out to literature outside of your domain where you could find any model?
I can start. I definitely agree. Most of the theoretical grounding of my work is based on literature in the bank adoption of electronic payment systems, or also in the hardware software industry. There's work on compatibility and standardization. So I've definitely consulted that work for theoretical grounding. And actually, my empirical specification, the instrument I use, is similar to one in a paper by Gaurasankaran and Stavens, which looks at adoption of electronic payment systems by banks.
Sorry. Yeah, our work was also definitely inspired by the economics literature in terms of network effects, and this is one thing that has become really clear from my conversation with Niam and some of the things he showed me, that there's the IS side has I think interesting things to say about this as well, and I think there's a lot of potential for cross-pollination there, and that's I think that's what makes forums like this so great.
Well, I think
since you did say I should correct you if you're wrong, I don't think there is a first order selection sample selection issue here, because we have everything. Since we're only looking at the choice within, everything else would drop out anyway, and all the other vendors are on the outside good. So in that sense, I don't think we have a problem there.
Okay. Thank you very much. Well, that's a good thing to have an economist on the panel, so he can correct you on your assumptions. So, thank you very much, everybody.